So I've been tasked to talk about optimizing biliary access. So when we talk about a difficult cannulation, I think it's important to recognize that even competent biliary endoscopists will fail some of the time, between 5 and 10% of cases. Previously, this was commonly referred to as the difficult cannulation, but it remained a very vague term because it was not really defined what a difficult cannulation actually means. And a difficult cannulation for an experienced endoscopist may be very different compared to a difficult cannulation for a less experienced endoscopist. What we know is that the most important complication of ERCP is post-ERCP pancreatitis, occurring in about 5 to 10% of cases. But when a procedure is particularly difficult cannulation, post-ERCP pancreatitis will occur more commonly, up to 20% of cases. So in this talk, I will define a difficult cannulation. I will then go on to discuss how can we avoid a difficult cannulation, and when your strategy fails, when should you reconsider something else? I have a difficult cannulation, or my guidewire is in the pancreatic duct, but and then briefly discuss when do we need to perform pre-cut and if everything else fails. So a very wise man once said that the definition of insanity is doing the same thing over and over again and expecting a different result. And I think this is particularly true when we discuss the difficult cannulation techniques, because if your strategy doesn't work, you need to change it. So the second point that I think is going to be important to make already at this time is that stick to the things that you're good at. So if you know a tool well, stick to that tool, but change your strategy when you fail to cannulate. So looking at specifically at how we can define a difficult cannulation, I think this has become easier based on work that has been done over the last few years. We would now be able to define a difficult cannulation, and there's also a scientific rationale for that, as well as implications, as I will show you in the next few slides. So a couple of years ago, the group from Michael Burke in Sydney looked at 732 patients, and what they could show, which I think really changed the field, was that if you cannulate below 10 times, you have a post-ERCP pancreatitis risk of about 4.3%. But as soon as you cannulate more than 10 times, the risk of developing post-ERCP pancreatitis really exponentially increased. So the take-home message was really the number of cannulation attempts define the risk of pancreatitis. From the same group a couple of years later, they also showed this again, identifying 73 patients out of 464 where a difficult cannulation, as described by their definition, occurred. And again, the same recurring theme. If the cannulation attempts exceeded 8 to 10, an exponential increase in pancreatitis risk occurred. So we have now the ability to define difficult cannulation based on the number of attempts at cannulation of the bile duct. The same holds true for time, although time is sometimes more difficult to use, but cannulation attempts exceeding more than 10 minutes really led to an increased risk of post-ERCP pancreatitis. So I think we can summarize this by saying a difficult cannulation can now be scientifically defined based on the number of attempts as well as the duration of the procedure.
Yes, you can put a little bit of tension on the sphincterotome, Larissa.
As endoscopists, we often have fear of diverticulums, but sometimes I think they're pretty useful because they often really show the way that the common bile duct is moving. If you have like a bridge of tissue in between, or the diverticulum pushes the bile duct away, you can cannulate perfectly in the right direction. So often they're helpful as well.
So I will ask to Larissa to give me the wire myself. So I like to feel the wire myself It's not because I do not trust the endoscopy nurse, but I think it's very useful because you know the level of resistance that you have on the wire. I will give myself a little bit of wire and try to cannulate in this way.
You can also see that here it's difficult because it's very floppy.
It's very floppy, yeah. So I cannot put a lot of pressure on my... Yes, please put some tension on the sphincterotome. No, that's too much. Yeah, a little bit more. No, yeah.
Peter, do you think it will help to go into the long position?
Yes, so it might help. So I can change indeed the position of my duodenoscope to get myself in a better position. Maybe I'll give it a try. But I fear, honestly, that this will not help me because I push myself out. So you can also try to maybe rotate the sphincterotome a little bit, although it's not a fully steerable instrument, of course.
Sometimes if you try too long, I mean, the stomach gets inflated, your position can be even more difficult. So
Indeed.
what I often do after a couple of minutes, I go back to the stomach, deflate, and I try again. And yeah.
It's a very good tip.
So you can see, Peter, we're very good backseat drivers. We're giving you a lot of...
So I'm sorry, guys, that you have to watch this. So if you want, you can go to the pre-recorded case. It's up to you. And we give it a couple of minutes. Yes, put some tension here, please.
That's why the session is a difficult cannulation session.
Yeah.
Does everybody here use a straight tip for a guide wire cannulation, or do you use a curved tip as well?
I normally use a straight tip.
A straight tip? You as well?
Okay, so maybe you can switch to the recorded video.
Yeah. And we will give it another 5 minutes and then...
Yes, we're still... okay.
Yeah.
So this is a case of an 80-year-old male who had a history of colon carcinoma with liver metastasis, and now he presented with obstructive jaundice and a narrow duodenum. There was an ERCP in a referral center, but the papilla could not be found because it was also between the verticula.
Hello everyone, this elderly patient is known with a metastasized colonic carcinoma, and he recently presented himself with an obstructive jaundice. And there is a rapid evolution of this of his cholestasis in the lab. The aim today is to do a biliary drainage. So we tried yesterday with a regular ERCP, but the problem is that his duodenum is also narrowed, and it's not very easy to get in front of the papilla. So today we are going to perform an endoscopic ultrasound to see whether an US-guided rendezvous procedure would be feasible, or rather a choledocho duodenostomy, depending on the site of biliary obstruction. So I'm now at the level of the common bile duct. You see that it's a little bit dilated, but not that much. And so I'm moving now downwards, and here you see that there is a large lymphadenopathy, which is compressing on this bile duct. And so this is the reason of his cholestasis, of course. I will now measure the diameter of the common bile duct. So it measures, it's a bit less than 10 millimeters. So this would mean that this size is not safe for placement of lumen opposing metal stents. So what I will try to do is do a rendezvous procedure in this patient and try to pass my wire into the duodenum, and then I will be able to pick it up and push myself, in fact, into the bile duct. If this is not successful and if I have my wire in place, I will have to fill the bile duct with sterile water in order to see whether we can maybe dilate the bile duct a little bit further, so that my bile duct diameter would be like 12 millimeters or more. And if I can achieve this, it would be feasible to place a choledochoduodenostomy with an 8.6 millimeter lumen opposing metal stent. But I think my first choice here would be a rendezvous procedure.
Hepatobiliary endoscopy, ESD and EMR. Then we have Dr. Len Verbeke, who's also an endoscopist performing ERCP and echoendoscopy in Mechelen and in Antwerp. Then we have Professor Schalk van der Merwe, who's a professor in the University Hospital in Leuven, focusing on hepatology and hepatobiliary endoscopy. He will give the first talk about the approach to difficult cannulation. And then we have the live endoscopy, where Professor Hendricks and Professor van Malenstein are doing the